Welcome to PROCURE Health Talks, a webinar specially designed for men affected by prostate cancer and their loved ones. The various topics covered in these webinars are intended to provide reliable information based on the concerns and questions asked to PROCURE healthcare professionals. Let's begin.
Hello, my name is Kim Sullivan and welcome to PROCURE Health Talks. Today we're going to discuss the two main side effects related to prostate cancer treatment, particularly after radical surgery. Those are erectile dysfunction and urinary incontinence, two issues that mean that this disease is still a bit of a taboo topic. But do these side effects affect all men in the same way? Let's start with erectile dysfunction. Men don't necessarily talk about it amongst themselves, but when someone has to go through treatment or surgery for prostate cancer, it is sure that he is going to think about this. Am I going to be able to have an erection after my operation? Thank you, Dr. Lebeau, for joining us today. We know that you're a surgeon, a urologist at Maisonneuve-Rosemont Hospital, and a department head at CIUSSS of the Est sur l'île de Montréal. Thank you. Thank you for having me. Let's start with some general questions. Can you tell us exactly where these nerves are compared to the prostate, those erectile nerves? And can you tell us if you can see whether those nerves have been damaged during an operation? Well, in fact, those nerves are around the prostate. If you think of the prostate like a piece of fruit, the nerves are like the peel of the prostate, and that is where we most often find them. We know that they're there, but they're microscopic. You can't see them with the naked eye, even during the operation, but we know how to avoid them. We can't always avoid them, but we try as much as possible, and we're never sure whether the nerves have been damaged or not. So you don't know that until after the operation. During the operation, we can see if they have been damaged because sometimes we have to cut them on purpose when it's a cancer that has spread. I often tell my patients that when we're treating their cancer and at the end of the treatment, that treatment was not effective. So unfortunately, sometimes we have to go a little wider around the prostate and then we do damage those nerves. Often we can preserve them, but that doesn't necessarily guarantee that that patient will be able to have an erection. So if you can preserve those erectile nerves, are all men going to get their erectile function back? That's a great question, and the answer is no. It's pretty simple because a lot of men, the day of their operation or even beforehand, they weren't having normal erections. So we can presume that if the starting point isn't perfect, the result won't be perfect either, and that's often how we go about setting patient expectations to see if they're going to get their erectile function back or not. A lot of times we have patients who have excellent erections and that is very well preserved, but it takes a fair bit of time to get that back. It's rare, but that does happen. And sometimes it's the opposite. We have patients who had very good erections, but who had very aggressive diseases. So we aren't able to preserve those nerves, but still they are able to get an erection. Preoperative erectile function is often a better determiner of recovery than just surgery. But it's also true that preserving those nerves helps in recovery. So you said recovery a lot in that response. And on average, how long does that take for patients to get their erectile function back? It really varies. It's pretty rare in the first 6 months. I've operated on hundreds of patients, and I would say it's pretty rare that a few weeks after surgery that they have an erection where they can have sexual intercourse. But usually that's within 6 to 12 months, but sometimes even longer. We say that the first 2 years are a period of a lot of recovery, but even it can extend beyond that time and they can still recover. But it's difficult to say, 21 days later, you'll be able to get an erection because that isn't how it works. It's different for everyone. You also mentioned earlier that it depends on what their sex life was before, how their erections were before. I would assume that that depends also on the baseline and what they see as good or problematic. There are men who think that their erections are very good, but when we look at that objectively on a questionnaire, it's not what someone else would call a very good erection. So it varies a lot. Also, sexual health is more than an erection. When I talk to patients, we talk about erections, we talk about erectile dysfunction, recovery, but I think it's also important to talk about a sex life outside of erections. Many men think that their sex life is going to stop if they can't get get an erection, and that's not true. It takes some resilience, it takes communication with your partner, being able to talk to each other. And also, in my experience, when we explain things well to patients, they adjust their expectations and they are generally less disappointed. So here's my question. Is an active sex life before the operation probably going to lead to a more normal recovery? Definitely an active sex life with well-functioning erections before the operation is going to help with recovery. And is there an age factor that you can identify? No, because that also varies a lot. I have patients who are 85 who say that they have normal erections. They haven't necessarily had surgery, but I mean on the normal aging spectrum. I have 85-year-old patients who think that they have a normal sex life and 42-year-olds who say that they don't. So it's difficult to say that there's an age that is the limiting factor, but definitely the older you are, the harder the recovery is going to be regardless of your erectile function before the surgery. Now let's talk after surgery, maybe 2 years after surgery. If you haven't gotten back to normal or exactly how you were before, does that mean that that's how things are going to be for the rest of your life? And is there a way to improve that? Yes, there's a recovery period and that takes time and we can't rush it. Sometimes we have to wait for the nerves to heal, and then stimulation can lead to erections, but sometimes that takes time. It would surprise me, for example, if we had a patient who had no erectile function, no sexual activity, and then one day it just worked. What happens a lot is that when things aren't going great, patients avoid sexual contact because they don't want to be disappointed. But then that's a vicious cycle because, as we say, use it or lose it. I give an example to my patients. If you want to run a marathon and you haven't trained, it's definitely not going to work. It takes stimulation to get your sexual function back. And 2 years later, it's kind of too late to start because we have some scar tissue, the tissue is less reactive. But if we have a slow progression, bit by bit, that can keep going after 2 years. So do you think that using a medication like maybe Cialis or Viagra, we hear a lot about those, can that help with self-esteem maybe? Yes, it can, but it's also not a magic bullet. What we see a lot with those medications is that it brings a big rush of blood into the penis. It brings oxygen that promotes recovery and healing. But the most important, if you were choosing between medication and sexual stimulation, is definitely sexual stimulation. Like I was saying, someone who isn't doing anything, who isn't trying masturbation, who is avoiding all kinds of sexual contact but is taking Viagra, that is never going to work. It's a tool, but we have to set realistic expectations with our patients. Someone who starts taking Cialis or Viagra 6 weeks after surgery, it's not very likely that that person will have a normal erection. It can happen, but often people get discouraged because it's not working. They feel like they don't know what to do. So it's important for us as clinicians when we see people in our offices, even before operating on them, I talk to them in a pretty open way because it's part of what we're tracking, to talk about their sex life, talk about what that represents, and to get them to not focus so much on erections. Because yes, there are people who won't have erections, but they won't necessarily be unsatisfied and their partners won't either. I think it's important to understand that. Now, is there a spike in the effectiveness of these drugs? Do they lose effect over time? No, there is no tolerance built up to that. It's not like a narcotic or where we have to increase the dose all the time to get the same effect. When these drugs work, they work, but there's the aging process, which is independent of prostate cancer treatment. Lots of people have erectile dysfunction who have never had surgery, but it's just the normal aging process means that their erections are less good over time. Lots of people think that after surgery, it might not only be difficult to get an erection, but it could be painful. Is that a frequent or normal side effect? It's not frequent, but it does happen. Sometimes orgasms can be painful. It's less common that erections themselves would be painful. That can happen when we do injections into the penis, which we'll talk about a little bit later as an alternative way to get an erection. We don't see that often, but it does happen, and that's due to scar tissue and fibrosis. So you said the longer you wait, the more scar tissue there can be. Maybe what's a better option? We encourage people to keep up their sexual activity because that's part of overall health, not just for the man himself, but in a relationship, we encourage them to have sexual stimulation if that's appealing to them. But we also respect everyone's choices. It's very important because a lot of people think about this a lot. I would say say that the majority of men aren't completely focused on that. And I think if we explain things well to them, then when they have realistic expectations, it's more rare that they're disappointed. So now let's talk about orgasms. And do orgasms continue the same way after surgery? So I think some men say that they urinate during orgasm. Why does that happen? So most often we see dry orgasms, meaning that there's an orgasm but there's no ejaculation, because when we remove the prostate, we disconnect all of that plumbing. So there's really no liquid coming out. Sometimes a little bit because there are some secretions in the ureter, and sometimes a little bit of urine. I'll talk about that more later. Does the sensation change? Often men will say that they have a feeling that is very similar to orgasms they had before, even without an erection. They reach orgasm, and that often surprises them. But people get used to that. It's very rare to have painful orgasms, but it can happen, just like we were talking about. But the orgasm can be equally satisfying. Sometimes people describe that, but that's more anecdotal. So sometimes there's a little loss of urine when there's sexual excitement or you have an orgasm. When we remove the prostate, we take out a valve that controls urinary continence, but it orients things toward ejaculation or urination. And when we take that out, then there's less regulation of that urinary continence. And to achieve an orgasm, there's muscular relaxation. And if the bladder is not empty, a few drops may come out. We hear that pretty often. So we suggest to people to go urinate before they have sexual relations to decrease the chance of that. But we also try to educate them. It's not dangerous. A few drops of urine, not for them and not for their partners. It's sterile. You can't get sick from it. You can't catch cancer. You can't get an infection that way. So I think really at the basis here is communication. And when we tackle those topics head on, meaning I'm not necessarily waiting for the patient to bring that up. Often people do, but often it's me who's bringing up the topic, and then they're often less disappointed. So when we talk about maintaining those erectile nerves, like you were talking about during surgery, and the man still can't get an erection even with medication or can't have an orgasm, what other options could he think about? Are there other things that you could have to offer to help that person? Beyond medication, there are different degrees of medication. When we talk about medications like Viagra, Cialis, Levitra, or that category of medications, but then there are injections that can be given into the penis that increase the blood volume and promote erections. Did you say that's a little painful? Yes, it can be painful sometimes. There are some people who describe painful erections when they give themselves those injections, but the majority of patients tolerate them and find they work quite well, even better than medications. But you have to give yourself an injection into your penis every time you want to have a sexual encounter. Then there are pumps that we can use. Sometimes those create negative pressure and can create an erection, or we can put an elastic band at the base of the penis to maintain the erection. And that could be done with or without medication, depending on the context, and often that allows enough of an erection that that person can have sexual intercourse. The next step would be a prosthesis. That's something that's mechanical, a small pump that is going to inflate the penis into an erection, or even a semi-rigid prosthesis that can allow for pretty satisfying sexual intercourse. When you look at the medical literature, those are the options that give the greatest satisfaction because you always get an erection. It's never not going to work unless there's some sort of mechanical failure. Medications can help, but erections aren't just affected by surgery. There's overall health, normal aging, diabetes, metabolic syndrome, that can have an impact, and then the whole psychological context. That's why I think it's important for us as clinicians to talk about it, because patients feel this huge dark cloud. They're so afraid that it's not going to work that then it doesn't work. And I often tell them, I have patients who are 20 years old who come to see me for erectile dysfunction and have not had their prostate removed. And for them, right, they're so afraid that it's not going to work that it doesn't work. So there's performance anxiety, and we have to help people with that. Now, that word prosthesis, that's kind of psychologically loaded because you feel like, oh no, this isn't going to be natural. But with modern technology, it could be very natural. You could inflate that as part of foreplay. It's just very natural. I don't know. I'm not sure that I would say very natural, but it can be very satisfactory. We do put in prostheses. It's not super frequent, but people who want them are often patients who are very motivated, rarely disappointed because they know what it's going to be like. I'm not sure if I would say natural, but this isn't some sort of like extra external pump that you have to pump up. No, no, no. It's not like you have a, diesel generator in your bedroom. It's a small pump in the scrotum. It's pretty discreet, and I would say even the person's partner could help with pumping that up during foreplay. So the thing about those mechanical options is even when you're stressed, you have a new partner, it's still going to work. It's not going to be a problem. You'll still be able to get an erection. And you don't even have to think about performance anxiety. Right, that's what I meant by natural, right? Everyone has their own definition of natural. So if you were going to offer your patients in order of priority the best ways to get an erection, if you remove those nerves during an operation, what would you choose? Or if you touch those nerves, right, you're right. We don't remove them completely, but we might touch them or traumatize them during that operation. And here's what I would say is what I was just saying to you just now is communicating well with patients and with their partners. For people who are in a long-term relationship, it's usually a little easier. People who are looking for a new partner, it's for sure that becomes more complicated. But often people are more understanding than you might imagine. I think it's also just to, talk about it. So all of that, we try to break down performance anxiety. So it takes stimulation. If you're not masturbating, if you're not having any sexual contact for months and months, it doesn't matter what you take, there's a small chance that you're going to have a full recovery. You need stimulation with or without medication. And for the great majority of people, it's oral medications like Viagra, Cialis, or Levitra. We bring all of that into play and regular stimulation. You put the odds on your side. And can you combine methods? Would you suggest that? Yes, because there is a, very mechanical function. I talked about pumps just now, and sometimes we use those with medication. You can use both of them. Not so much injections with oral medication. You should avoid that. A prosthesis with oral medication is totally useless because when we put in the prosthesis, we take out the part of the body that is the receptor to that medication. So we wouldn't suggest that. But yes, you can use more than one method. Everyone's different. Everyone has to go through trial and error and find the solution that works for them. And if we say that all patients are different, what about people on hormone therapy? Would you use the same methods or something else? So hormone therapy, which we use when someone has advanced prostate cancer, the goal there is to decrease their testosterone level. And if we look at the chain of thoughts that you need to have an erection, it takes desire, then nerve function, blood vessels, and the right psychological and hormonal environment. And when you have no testosterone, the first thing to go is sexual desire. It already takes a lot more oomph to have a satisfying sex life when you're on hormone therapy because a lot of men, it becomes mechanical. So someone who's taking medication, then they use a pump. It's not impossible to have sexual activity, but it takes motivation. And by definition, when you have no libido, then it's harder to get an erection when you're on hormone therapy. Okay, that's interesting. We were talking about injections and you said they might be painful. Is that the administration, the dosage? Well, we try to find the smallest dose that is effective, and we explain to patients and we show them how to mix up the medication and how to inject themselves. And then they usually go with the lowest dose that's going to work. There are people who are very sensitive, who are afraid of needles, and that can augment their pain. It's a really small needle, not like a mosquito bite, but almost just, so small, I tell my patients. And someone who is motivated, the pain levels are going to vary. It's hard to explain because it's everyone taking the same medication. But sometimes people have a lot of pain without a satisfying erection. It can happen. But the majority of people, we do sort of screening through our conversations with them. And generally, people are prepared for what this is going to involve. Do you have any tips? Well, you have to do the injection the right way. And myself, just as a matter of course, I tell my patients to bring their medications to my office. I show them how to mix it up. I try to demystify it a little bit. And for me, I'm a surgeon. I deal with needles and scalpels all the time, but this isn't the case for everyone. Someone who injects themselves for diabetes is generally more comfortable with the idea of injections in the penis. But often when we suggest these, people will say, oh my gosh, no, I definitely don't want that. And I think it's important to demystify it and reassure them, and that the first injection is often the most difficult. And so I try to help them with that, to come to my office or I just show them how it works. There are also clinics that help with finding the right dose, injecting it so that the patient feels a little more self-sufficient. But generally just a good explanation, going over the instructions, how to mix the drugs or inject them into the penis, that's enough. So when we've talked about erectile dysfunction, I think what I'm taking away from this is that communication, patience, and the psychological factor are things we have to work on. Yes, I think that's really important. And I want to tell people that focusing your whole life, your whole sex life on an erection, I think it's a mistake. It doesn't mean that people don't get their erectile function back. A lot do. But even so, your sex life is going to change, and I think you have to accept that. It doesn't mean that your sex life isn't going to be satisfactory, but I think we have to choose our words carefully and when we present them to patients. There are patients who are not satisfied with their sex life, but there are people who have a whole new sexuality that is totally satisfying to them and their partners. And you said a lot of patients come to you with questions. Yes, if you have questions, I think you should just ask them to your medical team if your questions haven't been addressed during your appointments. And myself personally, when I have men who are maybe 65 years old and I'm going to operate on them, I've treated hundreds. Everyone isn't the same, but I think they often have the same concerns. Now let's talk about urinary issues. It seems like most men who have prostate cancer have urinary issues after radical surgery. I wouldn't necessarily say the majority, but it is a major concern. So just now we talked about sexual function, but urinary function is everyone's daily reality. There are some people who decide to just put their sex life to the side for a while. Some people focus on it too much, but you have to go to the bathroom. So everyone does that every day, and unfortunately often at night as well. So it is often a more concerning problem. You talked just now about the mechanical aspects, and you gave us a very good visual, the plumbing and taking out that valve. And when you do that, do you replace it with something else? Can anything help? So when we do that surgery, we want to preserve those nerves that control erections, but they also control urinary continence on a certain level. And in the surgery, our goal is to take out the prostate, but to preserve all the muscles around it. It's pretty complex because urinary continence in men, a major part depends on the prostate because there is a sphincter that retains the urine. And when we take that out, the vast majority of men are going to have some incontinence, at least temporarily, and then it will quickly get dramatically better. But what we're trying to do is preserve the muscles and the nerves that are around the urethra, which is the channel that takes the urine from the bladder to outside the body. And it's very important to do exercises. It's like push-ups for your perineum to build up that external sphincter. So is that the Kegel exercise that women are familiar with? Yes, it's the same principle, those Kegel exercises. And physical therapy is going to be a little different for men than for women, but it's the same goal to contract those muscles around the urethra. And sometimes what we tell men, it's a little easier, is to think about contracting the anus. But when you contract your perineum, it's pretty much the same muscles when you contract the anus, and that helps preserve urinary continence. Sometimes it's not that easy. When people know or learn about this, sometimes the first thing they do is look on Mr. Google and try to look online to see if they can find some help. And as a urologist, do you show this to your patient? Are there physical therapists who specialize in this? Yes, a good proportion of our patients do physical therapy, and that will help them recover faster. Some don't do physical therapy. They do Kegel exercises and they also recover. And then a small percentage of men will just remain incontinent, and that can have a significant negative impact on their quality of life. Do you think Googling is helpful? Well, sometimes it helps people understand exercises like Kegels. And we warn patients that the day when we take out their catheter, they're going to be incontinent, and then they're less surprised. And I would say in the first 6 to 8 weeks, incontinence will definitely improve, but sometimes people don't believe it. When we see them too early, I would say, after surgery, they're often quite distressed. But when we present them with all of this information and tell them what's going to happen, Sometimes people think this is going to last forever, but nature generally works quite well and they recover pretty quickly. For someone who has just been diagnosed and who is just hearing about this, can you explain the word catheter? What is that? Do you put in a catheter during surgery? So when we do this operation, we put in a catheter because it's between, it's a channel that goes from the urethra to the bladder because the prostate is in the middle. We take that out. So then we have to re-sew those other two pieces of the body together, and we have to direct the flow of urine so that they heal well. And we leave it in about 7 days. It depends on the technique, but 6 to 7 days. And when we take it out, a large percentage of men are going to be temporarily incontinent, just temporarily, because there you don't have the system that you've used your whole life. We learn to hold in our urine when we were maybe 2 years old, and we just have to retrain ourselves doing those exercises for our muscle tone. There's a lot of recovery in the first 2 months, and it's not always perfect. Sometimes there are people with no incontinence when we take the catheter out, but not everyone. So if that happens, you can't think that it's not normal. And then that recovery, is that also gradual? Yes, I say people recover a lot in the first 2 months, but really the first 2 years. Right, that's the next question I was going to ask. Is the recovery gradual? Does that get better over time? That's what I was going to ask. Or at what point in time should you worry if you don't see any changes? So I think worrying is never a good idea. I think you should never have this idea that at a certain point you have to worry because everyone is different. But you also shouldn't hesitate when you see your urologist after your treatment. There are critical questions like incontinence that it's a good chance to talk about them and see what kind of impact that can have, and it really varies. I've had patients who are really active marathon runners, cross-country skiers, who were really upset if they just have a small amount of urinary leakage. But then I have patients that have more urinary leakage, but they're more sedentary, so it's less of an inconvenience. And for us, it's important to listen to what people are telling us and to see what we can suggest for a certain person and to reassure them about this urinary leakage because it has a different impact for everyone. Like we were saying before, and we talked about all patients aren't the same, we talked about hormone therapy. And in that case, really all patients aren't the same. What happens if you have to have radiation therapy? Well, definitely that is going to change your recovery because we're going to have scarring when we do radiation treatments, especially right after surgery when you haven't recovered a sufficient amount of urinary continence. It's like you kind of freeze that recovery time and slow it down. You're not necessarily going to be incontinent, and it is pretty rare that we do radiation right after surgery. It's when we're really concerned about the progression of that cancer. And we have to sort of weigh the functional aspect, the cancer aspect. But when we do that right after surgery, it's because we really want to get to the root of that cancer. It takes a certain amount of resilience. Just now you were talking about keeping more normal erectile function and that it's helpful if you had an active sex life before the operation. Is the same thing true of incontinence? Are there things you can do ahead of time? Well, you can try Kegel exercises while you still have your prostate, at least to learn the movement. It's not wasted time because you learn the exercise. Does that change recovery time? Generally, people who do that before the operation, they are very motivated, and so they're still motivated after the operation. And that doesn't fix everything, but it can help. So there are all kinds of urinary problems other than the prostate. For example, hyperactive bladder makes it more difficult to stabilize the bladder after surgery. And when we're talking to patients who we're going to operate on and we're talking to them before the surgery, that's one of the things we discuss. How often should patients do those exercises? It depends on when they're doing them. We suggest 5 to 10 repetitions every day or twice a day, especially right after surgery. Sometimes people feel like they're not doing it very well, or we have that impression. Then it can be useful to send them to a physical therapist to learn those Kegel exercises, because sometimes they're not contracting their muscles in the right way and it's counterproductive. And sometimes if people feel like like they're not making that much progress, physiotherapy can be helpful. On the other end of the spectrum, we have hyper-motivated people who just do it too much. Like if you do 2,000 push-ups, the final 100 push-ups probably aren't going to be that great. So you have to limit the number of repetitions that you do and have an optimal number for your muscle tone. Can it be painful? When you push a muscle to fatigue, it can be a little painful if you do it too much. Okay. Is it possible for men to get their urinary continence back and then lose it again? Yes. So because this is a muscle that we're stimulating, and if you stop doing it, then that muscle can lose strength. And when you don't have a prostate anymore, the urinary continence mechanism is more sensitive than it was before. So you really have to keep up with it, actively contract that sphincter. And we often see people who say at the end of the day, they're losing a little more urine. It's like muscle fatigue, and you're just losing a little bit of control. Or sometimes people are, having a drink before or after dinner, or having an alcoholic drink, and it's like that muscle tone gets lost because people are relaxing at the end of the day. And if you do those exercises, follow all of your doctor and physical therapist's instructions. Do you have any other suggestions? Yes, there are still prostheses that we can use if you're still having incontinence. Those are called artificial sphincters. We were talking about that for erections, but it's the same principle. It's a little ring that we put around the urethra, and we can inflate it so that it squeezes or crushes the urethra and the urine can't get out. It works really well. It's not a totally benign surgery, so we want to think about it before we do it. Would you call it a last resort, and is it permanent? Yes, it's permanent. Would you call it a last resort? Yes, because it means we tried a lot of things before. When I was talking about the Cadillac of prostheses, because there are all sorts of devices we can use, there's a gradation. It really depends on the impact on the quality of life, the problems that incontinence is causing. We just have to adapt to what the patient wants. Just now, you talked about patients who are athletic and that might be more traumatic for them, these small urinary leakages, while for some other people, not so much. Can you continue playing sports after surgery? Oh, yes. It's not true that athletes won't get back into physical condition. I have marathoners, track and field athletes, and then I have people who have no urinary leakage, almost none at all. And sometimes people who don't have much urinary leakage, but they're very distressed about it. But yes, after a few weeks, generally, I think that we say about 6 weeks for everyone. It depends on the type of surgery and it depends on the person. But after 6 weeks, generally, there aren't any restrictions on physical activity. How about riding a bike? Often it's some local discomfort that makes people not really want to sit on a bike saddle. In the first 6 weeks, we don't necessarily recommend sitting on a bike seat for a long time. Because the motion is in that area that's been operated on. So 6 to 8 weeks, but there are really no restrictions anymore. And it depends on what you mean by bike riding. For some people, that's 500 kilometers, and some people, it's 5 kilometers. So you have to sort of adapt there. So if I'm understanding this correctly, in both situations, you need to prepare before your surgery for what life is going to be like after surgery. Yes, definitely. And even beyond sexual and urinary function, the better prepared you are, the better things are going to go. I assume that most men are really eager to get back to normal life after surgery. Are there risks for someone who overdoes it, like you were saying just now? Well, do they do too much sports, too much exercise, too much stimulation? And it depends on the question. For someone who is exercising very intensively, doing weightlifting, things like that, there's always a risk that their incisions aren't totally healed, and then they're also not at their maximum strength. So we do see complications like that, but it's pretty rare that people pursue their recovery in a way that's too intensive. Often, people just have to move the needle a little bit. And I would say the more proactive we are in managing all of that, the better the chance is of a full recovery. Well, that was my last question, and now I'd like to ask you for your top 5 pieces of advice, top 5 tips. I often tell people that we're afraid of what we don't know or what we don't understand. So the first thing is to go look for information. It sounds kind of crazy to say this, but prostate cancer is a quote unquote good cancer in the sense that it really is not an out of control disease in most cases. We have time to think it over and make an informed decision. And when people come back, they generally are a little more at peace because they've informed themselves and they're better prepared and they can make that informed decision. So my first piece of advice would be take the time to just breathe a little bit. Second tip, which I tell all my patients, is don't start from a place of fear. It does no good to get irritated and to get worried. There is a situation, we've got a situation, and I tell them that, this is what I do, managing this kind of problem, and together we're going to face it. And after that, I would say realistic expectations, to not envision that they're going to feel better after the surgery than they did before. There are people who were sort of feeling overwhelmed before the surgery, and that's not going to be better afterwards. And I think that that doesn't mean that the outcome isn't going to be satisfactory. And I think we can, let's see, what would I say? That's 4. Okay, we're up to number 4. How about I let you pick the last 2? That you can continue playing sports? Yes, definitely. You can continue exercising and playing sports. Life is definitely not going to stop. Often it's a parentheses that means that for 6 to 8 weeks, your life is going to be very much impacted. But our goal is, like I say to my patients, in 6 months, it's just a bad memory. And maybe you'll have some after effects, but not a huge impact on your daily life. And most people are satisfied with that. And number 5, let's say, be patient, like number 1. That's the end of the answers. What other advice would you have for our patients? And I think I can never emphasize enough the importance of being informed, that when you understand something, you're less afraid of it, you're better prepared, and you recover better. The internet is a source of both good and bad information, so we try to send people to reputable sites like PROCURE, where the information is validated, where we know that it's objective, and people can go get information, ask questions, feel at ease, and get answers that have been validated by scientists. And that's something that I think is really important. I think it's also important to tell patients never start from a place of fear. Often when you're diagnosed, you feel like your life is over, but that is never true. And what I try to tell patients is, for a short time, we're going to see each other a lot. We're going to treat this problem, and our goal is that in a few months, it's just a bad memory. Your life is going to be kind of on hold for 6 to 8 weeks, but then after that, you'll be in recovery, but your life is certainly not over, and we want you to have as normal a life as possible. Dr. Lebeau, that was so interesting. Thank you for joining us today. I'm sure that you answered a lot of questions, but those of you watching at home, don't forget that it's totally normal to have questions between your appointments or your treatments, and that's why you can call PROCURE 7 days a week and talk to one of our health professionals who will answer your questions.
We warmly thank our experts and our partners for making this webinar possible. To find out more about the tools and resources available to you, or to make a donation, visit procure.ca. Thank you for your support.